Okay, let's back up. Thank you all for joining us. Thank you to Parisa for coming. This is going to get much better because Parisa is a great presenter. She's been with us before, and welcome back to Parisa, who is a pain medicine and anesthesiology board certified individual. She received her training at University of Southern California. We won't hold that against her, and has been practicing at UCLA ever since. She practices multidisciplinary pain management by utilizing not only procedures and medications, but other specialties to help improve patients' pain. She's a strong believer of physical therapy and prevention to avoid damage to our bodies. So that is all I had to say to you this morning. And without further ado, Parisa, you now have the floor.
Thank you for the introduction. Hi, everybody. I am still loading my PowerPoint, but I do want to tell you guys, this is sort of the talk I give almost most of my patients that come in with pain. So I thought this would be really nice to kind of go over how to help your pain from it going from something simple like a muscle ache to something more problematic, and how to avoid coming to me. So I actually am an interventional pain medicine doctor at Encino. If there's any questions or concerns, I think you guys can share my email with everybody. You can reach out to me. And of course, the first day that I'm having a lot of internet issues today. One second, I'm going to try one other thing to see if it works. Let's see. Can you guys hear my gardener in the background? The door's all closed. Okay, good. So speaking of the morning, so this morning, my nanny called in and said has COVID.
Oh, no.
And my kids are off school because of some teacher development. So imagine that. So my life. Yeah, but thank God I have so much help. I can't really complain. My mom came to rescue, so it's really nice. All right, let me just, it worked. Okay, give me 1 second. I'm going to log in with my computer. Yes, good. And then can I share my screen, Maria?
Yes. Let me see how I can get the.
Can you make her the co-host?
Okay. Make co-host. Here we are. Okay. Yes.
Perfect. I'm going to log off of this and join you guys on my computer. Okay, we are in business. All right. Can everybody hear me okay?
Yes, perfect.
I can't hear you guys.
I think you might have to make her a co-host again, Maria.
Okay. Thank you, Lam.
No problem.
All right, I'm sharing my screen now. Let me know when you guys see the PowerPoint up. You guys see it?
Yes.
Yes.
Perfect. All right. So title of this presentation is In Pain, Stop Hurting, Start Living. Again, my sort of quick where I am. Origin of pain. So this PowerPoint is sort of like just a way of me knowing where to go. Most of it will be talking and kind of educating because it's kind of hard to write all this down. Origin of the pain can be from swelling, muscles, bones, and nerves. Swelling is sort of you hit something and then you get a lot of inflammatory responses there and you get a swelling and that can cause pain, that throbbing pain. Muscle pain is usually sort of back pain that's spread out through the back. So like if you ever experience pain kind of in the back and goes up and down, it's probably not a nerve because there are no nerves that go up and down that way in your back. When you press on it, it hurts. It's probably from muscle. It usually you usually wake up with the pain. You wake up, you're like, oh, I'm so achy or I'm in pain. And then it kind of gets worse when you use that muscle. Comes and goes. Those are usually muscle pain. Bone pain, it hurts with extension and flexion. Deep aching pain, usually chronic, usually occurs around age 50. Nerve pain, the most critical type of pain is where I actually really come in and try to help the patients with interventions because it's really hard to target and help with. and it usually radiates distally. So when I said distally, usually our nerves start from the spine and they go outwards. So let's say the neck nerve kind of goes from here, goes up to the head. Some people get headache from the nerve being pinched. Lower ones, they go to the arms. A little bit lower, they go around the waist to the belly. And then the lumbar spine goes from the lumbar and radiates down the leg or around the thighs. So those are usually nerve pain. So if anybody ever experiences those, that's what it is. How does pain usually worsen? Is unfortunately, I think a lot of times it starts with a muscle issue. So what happens is I'm a victim of it. I have a lot of muscle issues, right? So I get like this, I don't know if most people experience it right by the scapula, right under there. It kind of hurts, it throbs, it goes up, it goes right, or it goes left, and it just really hurts. So what we do is because we have muscle spasm, we stand a little weird, or we avoid using that arm, or we avoid moving in the right appropriate way. So what happens is that muscle gets tight, makes you do abnormal activity, because the way we're supposed to be doing things is moving all of our muscles and bones together. It's sort of like a coordinated movement we're supposed to be doing. When we have pain, we change that coordination. And what that does is it causes mechanical issue. So if you hold your arm in a different way, what happens is the arm can have issues. If you're kind of leaning towards that side, your back will have problems. And that's when the bone and the nerves start getting affected. And then what happens when your bone and nerves get affected? It goes into a little cycle. So bone and nerve cause more muscle spasm cause more bone and nerve issues. And so you end up in my clinic. So it's really important for everybody to understand that we need to move. So prevention and improvement of pain is mobility, 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 and then physical therapy if you can't do it on your own. So this is like the biggest thing everyone just kind of underestimates. I get a lot of people come and say, I just don't like physical therapy. Well, it's not about liking it. It's about what we have to do to help our pain and to help our life. So walking is wonderful. If you get a little pain, sometimes when you walk, it actually gets better. So exercises that I recommend to everyone, to really encourage everyone to do, whether you have pain or not, is swimming, Tai Chi, walking, and reformer Pilates. These are 4 exercises that I don't think anybody can really harm themselves doing. Even if you have, if you're elderly, if you have some pain issues, these actually shouldn't really affect it. Of course, if you have a spinal stenosis, you really have a weakness, that's a different story. We don't want you to be walking when you have weakness and fall and break your hip. But if you have no weakness and you're able to do it, these 4 exercises, any of them are really great. Some of my patients come to me and say, oh, I want to do yoga. If you haven't done yoga, don't do yoga. I can't even do yoga. Yoga really requires a lot of strength, which if you don't have, you could hurt yourself. I've had a lot of yoga accidents, actually. So some tools that I tell my patients, pretty much most of my patients, to have is foam roller and massage gun. So foam roller, I hope you guys can see my mouse. You could do a lot of exercises on the foam roller. It's very easy to actually look up exercises in the foam roller and do them at home. I personally use the foam roller at least every 2 days. If I don't use it for about a week, I suffer because of my lifestyle. I don't sit well. I have a bad posture. I'm on my phone all the time. I have my 2 children. So it really makes a huge difference for us to make sure we take care of our body and increase the sort of the mobility and the range of motion of our spine and on our body. The foam roller can be used in multiple different ways. One is by just laying down on it and kind of stabilizing the spine and opening up the chest. That's something that we have to always remember. In the last probably 10 to 20 years, we have learned to be this way because of computers, phones, work. We all sit down at work. So we need to learn to open up the muscles. And sometimes I always remind myself, okay, it's time to do shoulder rolls. So I roll my shoulders. But the foam roller really helps us doing it without that consciousness. So foam roller is one thing. They have different sizes. I always get the longest one because it can be used for everything. Massage gun is another one. There are multiple massage guns. The original one I think was Hypervolt, but now there are multiple different companies that make it. Amazon has their own, Costco has one, but it's wonderful because it gives you a massage at home. It can open up a muscle spasm without you needing to go to somewhere else. Especially with COVID, I feel like we're all a little bit more conscious of things. And so I always tell my patients to get a massage gun, and then I'll go over exactly which ones to use and how to use it. But the beginner ones are the flat surface ones. So this one and this one. And those are kind of a little bit easier on the body because the deeper you want it to go, the more ball looking head that it needs to be. So that's a massage gun. A hand roller, which is something like this, where you can actually roll it on your thigh. So a lot of people suffer from something called greater trochanter bursitis, which is that on the outside of the hip and it goes down the leg. And this is pretty much the only real thing you can do with it, which is to go over the lateral thigh and go over the muscle to open up the spasm, to really try to give a break to your bone that's right under that muscle. You can also use it for other reasons, but really that's the biggest one I encourage my patients to use it for. And then TENS unit. If you have a pain that's just not a muscle pain, if it's a nerve pain, or if it's something chronic, mechanical, a bone issue, you can actually get a TENS unit. It comes in multiple different forms. Insurance is covered, but really Amazon has it for a pretty good price. You just have to look up TENS unit. There's like 1,000 options on Amazon. I say Amazon because I buy everything there, but of course there's medical supply places everywhere. But what it is it's an electric signal that what it's supposed to do is distract your mind from the pain. So it only works when it's on. Some people, it irritates them. Some people it works. It depends on what your problem is, and it depends on your own body. But the way it works is you just kind of put it on wherever it hurts, so around it. So let's say my shoulder hurts. What I would do is I would put the 4 kind of around where the problem is, and I would start on the lowest setting and keep going up until I get results without it having any issues. And so that's a TENS unit. And what it does is it sends signals to each other, and it's supposed to distract you from the pain. For some patients, it works great. For most patients, it doesn't, but it's worth a try. Now, foam roller. Some things that I encourage everybody to do is we don't use our thoracic spine. So I wish I had my model. I should do that for my next talk. So I used to take it to actual talks. But so we have cervical spine is the neck. Thoracic spine is the middle, and lumbar spine is the lower. We don't use our thoracic spine a lot. We have learned to kind of move our neck instead of moving our body, right? So we end up having a lot of spasticity and a lot of tightness in the thoracic spine. And what that does is it puts more pressure on the lumbar spine and the cervical spine. So if you have a foam roller, if you buy one, look up thoracic mobility exercises on Google. You will see a bunch of them, and try to do a few of these exercises. I promise you will not regret it. It feels great. You feel more sort of loose. You can move your body better. It's great. Again, these are the exercises that I do pretty much every other day. And then myofascial release, you could do with the foam roller. So if you have a tight, let's say lats, so here it hurts, or sometimes what happens is you get a very tight chest and you actually get pain and numbness in the arm because of the tightness of chest. So if you ever suffer from it, you can actually press and it hurts. You actually can roll it. You can use that or a tennis ball, but I do like the foam roller for it. I feel like it's a lot less chance of me hurting myself and a lot easier to use because I just lay on it and kind of roll. The massage gun, only use it on a muscle or tissue. Don't ever use it on bone. Don't use it on any sort of like near the spine, because it is a percussion kind of thing and you can hurt yourself, especially if you have osteopenia or osteoporosis. There's many different settings and massage tools, but I always say start with the lowest setting on the flat surface and advance as you can tolerate. But the massage gun is actually a really, really great tool. Okay, at-home treatments besides the tools to kind of prevent further issues. So let's say you have tried all of that and you still have pain and you say, you know what, I really don't want to go to a doctor right now. It's not something I'm interested in. You can do ice or heat. Everybody's different. I love heat. I don't do ice, but some people love ice. The theory behind it is ice works for acute injuries and heat works for sort of prolonged issues. So if you've had this problem for a while, heat may be the better option. There's Tylenol, and Tylenol arthritis works so much better than regular Tylenol. So try Tylenol arthritis if regular Tylenol doesn't work. And if you do Tylenol, you can take up to 1,000 milligrams to see if it works. The minimum you should be taking is 650 and then 1,000. So the extra strength one usually doesn't do much. You can either do 2 extra strength or 2 of the regular Tylenols for it to work. But tenor arthritis is my favorite. And then there's NSAIDs, so non-steroidal anti-inflammatory drugs. So that's including ibuprofen, Aleve. What are the other ones? There's another one. I know there is. Anyways, naproxen, those are the generic, but there was one more I thought. And then magnesium supplements actually really great for chronic pain. It usually works for like the all over body pain, but it's a great thing to have anyways. It calms down the body. It can help you sleep. I prefer the powder over the pills. I don't think the pills are actually very effective. The powders, there's a calm one if you have a problem with sleeping where you can put it in your drink at night and drink it. I really like magnesium supplements. And then there's turmeric. I'm not sure how effective it is, honestly. It's gotten a big recognition. I think the problem is it's not truly like pure maybe, but it is a great anti-inflammatory. So it's worth a try. But, most of these turmeric and alpha-lipoic acid, you do have to use it for about a week for you to notice some improvement. And there's a lot of topical creams and topical patches. My all-time favorite is Salonpas patches. It does smell like menthol, which I enjoy, but some people don't like it. But they have the lidocaine as well. But I really, really like the patches because you put it on, it lasts a while. You can put on for 6 to 12 hours. My favorite is actually for the neck. For the low back and other issues, it may not go deep enough. But if you do have some neck discomfort, you can't really use the massage gun on there because it's a very sensitive area. And topical creams can kind of wear off a little bit faster. So I do the Salonpas right on my neck. So I bend it forward, put on the Salonpas patch, and then go along my day. It works pretty well. And then there are some like prescription patches, but they're actually not very prescription topical patches. They're unfortunately the lidocaine patches that are prescription are very fake now. Original one, the lidocaine patches were really wonderful, but the new ones are not. So the Salonpas patches I've had better results with than the regular. Now, when you go to the, these are the first line again. So anti-inflammatory, topical, and then muscle relaxants. But I'm going to go over, these are the prescription treatment options. So we have NSAID, anti-inflammatories, which are things like meloxicam and Celebrex. So you have the over-the-counter, and then you have the ones that we can prescribe. The prescription ones last longer. So they're supposed to be every 24 hours instead of having to take it every 12 or 8 hours. And then the good thing about the prescription ones, they're not supposed to irritate the stomach as much. As we get older too, we end up having more stomach issues. So you may not tolerate it as well. I have never been able to tolerate them. So I do the prescription ones only. But the problem with but I have had patients say that they still had stomach issues with the prescription ones. The problem with NSAID is you have to avoid it if you have any kidney dysfunction. So it does affect the kidney sort of circulation. And so if you do have kidney problems, it can be bad for you. If you don't have kidney problems and you take it as recommended, it shouldn't affect your kidney. Muscle relaxants. They're called muscle relaxants, but really we don't know how they work. But they're supposed to help decrease pain. I'm not sure why we call them muscle relaxants because I'm not sure if they actually relax the muscles. There's only one that is supposed to kind of relax the muscles, and that baclofen, I rarely use that anyways because it makes people kind of drowsy. But there's multiple muscle relaxant options. Methocarbamol, which is Robaxin. There's cyclobenzaprine, which is Flexeril. They either work or they don't. This is not one of those medications that you should keep taking, seeing if it's going to work. So the NSAIDs and the muscle relaxants, when you take it after an hour, if you don't notice any improvement, don't waste your body on it. So put it away, try something else or try a different one. Neurolytic medications. So these are medications that are supposed to help with nerve problems, but they do work for non-nerve pain too. Most of them are actually anti-seizure medications that calm down everything, including your pain that is coming from the nerves being fired up. So when we get pain, what happens is the signal kind of goes, and it keeps sending these signals through the brain. By increasing the threshold of how much of the sodium and the calcium need to come in, you're actually decreasing the amount of signals that are being sent. So it's going to throw out a little bit less. That's how the neurolytic medications work. So it's anti-seizure, calms down everything, including the pain nerves. Those are things like gabapentin, pregabalin, which is Lyrica, or Neurontin. And there's multiple other ones, but those are the two that are used mostly. There's another one called Topamax. It's Dopamax. If you're ever on it, it's a weight loss regimen too, but a lot of patients have some issues with it because they feel like they're very kind of dopey. Dopamax. And then the next category is the antidepressants. There's two different categories we use for pain. There's the NSRIs, so the neuroepinephrine serotonin reuptake inhibitors, which includes things like Cymbalta, duloxetine, or Effexor, venlafaxine. I always make a mistake with saying that word, but so those are the two that are in the first category, the SNRI, which are the more commonly used one because they have less side effects. And then there's the TCAs, tricyclic acid, which are things like amitriptyline, nortriptyline. I'm actually not sure about their brand name. I didn't know at some point, but they're not really brand anymore. So we don't really use the brand name anymore. But these are also antidepressants that work really well for pain. Actually, these are sort of first-line drugs for a lot of problems, things like fibromyalgia, trigeminal neuralgia. So things that are usually nerve-related, these are the first-line drugs for them. And then the last one is opioids, which we hear all the time about how bad or how good they are, depending on who you talk to. And then I'll go over the opioids mostly because I do think this is where we get a lot of issues with as to, the patients come, they're not sure if they should take it, if they shouldn't take it. Some people are really against it. Some people are really for it. But the bottom line is short-term use of opioids is okay. You have an acute pain, you're experiencing, let's say you've had surgery, you've had an injury, and it's really other things aren't going to be working, or you can't take anti-inflammatories, or Tylenol is not working. It's okay to take short-term, more than okay. People come in with worries about addiction. There's actually a genetic component to addiction. There's all these studies. You either have it in you or you don't, but you'll never know until you unfortunately get there. But usually if it's short-term, even if you're addicted, you will seek help because it's not something that that it's going to be done. Long-term problems with it, you build some tolerance. So if you've been on opioid for a very long time, you realize it's not working as well on me, so I have to go higher. Or you become dependent on it. If you skip a medication or if you don't have it that day, you get withdrawal symptoms. And that can be actually pretty uncomfortable. Supposedly, we can't die from withdrawal of opioids. It's just you feel really horrible, but it is a very bad feeling. And some people do have to go to the hospital because of all the nausea and the vomiting. And then there is addiction, which is the worst part of things, right? You get addicted, you use it for other things. If you can't get it from your doctor, you go on the street, or you use your friends, or you use your loved ones, whatever it is. And then the side effects of opioids is not very minimal. There's a lot of like, so this is the short term. So there's a lot of sedation, there's a lot of drowsiness. A lot of people actually have behavioral changes. Some of my patients come in and say, this is for long term, but they come to me and they say, I just didn't feel like myself. I'm so glad we came off of it. And they don't realize it until they completely come off. They're like, now I feel better. My family says I'm less irritable. My family says I'm more pleasant to be around. Of course, initially that's not the case because they're suffering a little bit. But after they really are off of it, they do really well. And then with long-term use, actually, people can have stomach issues, either distension, bloating, nausea, and vomiting. They can get this thing called gastroparesis, which is actually where your stomach doesn't function as well. So it doesn't get rid of the food fast enough. And that's why you get the nausea and vomiting. You can get liver damage, constipation. As we get older, we have more side effects with it. And then memory issues. There's been studies that people have been on it for 10 years or more have had major memory deficits compared to the ones that haven't been on it. It's kind of hard to be unbiased, but I could see why, because it really changes the chemical balance in your brain and the body. And then hyperalgesia, which is where you end up having more pain to a stimulation that wasn't as painful for you before. So let's say you get an injury or you have a surgery, your requirement for pain medication is a lot higher because you experience a lot more pain from it. And hyperalgesia is actually a very known fact about opioids. So that's about opioids. Oh, I have a chat. I'll go over that question. Okay. And then there is procedure. So let's say all of those things didn't work, medication doesn't work. That's when my interventional sort of skills come in. I tell my patients all the time, you got to try conservative therapy before you do interventions, because interventions, unfortunately, don't really fix your problem. They do help you function more. They do help you kind of get over the hump, but they don't actually help the problem. But let's say you aren't doing much exercise, you're not active, you're laying in bed all the time, probably the benefits and the risks, you should probably do the procedure, because that's a lot worse for you than getting the procedures. So procedures that are offered, joint injections. So simple things like knee injection, wrist injection. There's facet joint injection, but I'm going to put that separate. So anything that's sort of going into a joint, shoulder injections, those are all joint injections. We also have muscle injections, but those aren't really technically real procedures because they're in office, quick, no risk. There really doesn't need to be anything major with it. And then epidurals. Epidural is when we inject steroids into the spinal nerves. So whether it's in the middle or on the sides, every spinal nerve, including the spinal cord, has a sheath around it. And that sheath has another sheath on top of it. Epidural is when we go between the two sheaths that are covering your spinal cord. There's a sort of an imaginary space, and we put the steroids in there to decrease inflammation, to give you a better quality of life. Again, we don't fix the issue. All we do is decrease the swelling, so there's more room for the nerve, so you don't feel the symptoms as much. It may need 1, it may need 3, or you may not respond to the epidurals. If you don't respond to the epidurals, that's when we think about surgery. If you do respond to the epidurals, we try to prolong the surgery as much as possible. And the reason is because with time, things get worse. So, you don't want to keep doing surgery or get a fusion and then later on not know what to do with it. Because usually any spinal fusion, that means we basically put bones and we put screws and metal. After about 5 to 10 years, people do have problems with it. There are some cases that longer, but usually 10 years, I would say, is the average where people start getting issues with the because it's not mobile, they start having issues after the surgery. Then there's facet joint injections. So you may hear like a lot of times, oh, your facet hypertrophy or facet arthritis. That's the joints between the vertebral bodies. So the spinal cord is protected by two sheath, and then right outside of it, there's the bones. Those are vertebral bones. Those are attached. That's how we can move up and down and twist, because there's a joint in between them. So it gives us mobility. It's not very stiff. So facet joint injections, we can go in there. Nowadays, we don't do facet joint injections as much. We do something called lumbar medial branch block, which is right outside the facet joints. What we do is we do a test around the joints. These are nerves that go to the joint. And then if you get relief, then we do the burning, which is the radiofrequency ablation. And then if none of these work, there's something called spinal cord stimulator. I personally would do that before I have a fusion. It's different if you're just going to go clean up some bones and everything. But if you need a fusion, I would do spinal cord stimulator before that for sure. Because what it is 2 electrodes in the spine with a battery in the butt or in the back. And you charge it every day, or you can get the non-rechargeable one that lasts less. And it stimulates the spine, and it stimulates the to each other to kind of distract your spine from the pain. It works pretty well too, but again, I would say about 10 years is when people start saying it's not as effective anymore. Okay, I think that's pretty much it. Do you guys have any questions about the things that we talked about? And then let me actually, do you have any questions before I answer what's on the chat? No, okay. So it says, is there a better time of the day to best do exercises? I do mine shortly after waking. Actually, that is the best. So the ideal thing to do is do morning and night. So you want to start the day with stretches so that your body's kind of loose and you can do things. And then you want to end it so that whatever has been sort of the day's toll on your body, you're trying to get rid of it. So I would probably say if you have the time, I would do 10, 15 minutes in the morning, 10, 15 minutes at night. Any other questions? Awesome. Well, I thank you all for your time. And then Maria, you can always share. Oh, somebody said something.
I have a question, please.
Please.
I know magnesium is a component of, say, a multivitamin supplement. Is that enough to make any impact, or is it better to, as you say, try the powder?
I would do a supplement. So you're not going to be overdosing on the magnesium if you just take a supplement and the multivitamin. The multivitamin doesn't have as much as the powder does. I would say supplement it with the powder and see what you do. The multivitamin has very little magnesium because magnesium is not something that you should be lacking anyways.
All righty. Thank you.
You're welcome. Okay, Mary, I think, Anne, go ahead, or Anna.
Hi, you had alpha lipoic acid on your list, but you never did, it was under turmeric, but you never did comment as to its effectiveness.
Yeah, so I think I did, but you're right. I wasn't very clear. So turmeric and alpha lipoic acid are the ones that you need to take about 2 weeks before you notice an improvement. Again, I'm not sure how much they help. Alpha lipoic acid, I know, works really well for patients who are on statins and get muscle aches. This actually, I've told some of my patients and it worked pretty well. But both of those, I'm not quite sure. There are some studies that say it's supposed to help, but from my experience with my patients, it's been, maybe it works. But with the alpha lipoic acid, you do have to be careful with some interaction with your statins, I believe. But again, it's very rare that it would cause any issues, but you just have to be careful and be aware of it.
Thank you.
Question, how much magnesium per day do you suggest?
I would have to look. It's whatever the supplement says. Let me see. I just tell people to follow the instructions, but let me check.
Thank you.
Of course. Thank God for the phone. What did people do in the old days? Like go to the library and search? It's crazy. Everything's at the bottom of fingers. So I know the normal is around 200 to 400, but I want to see the powder ones if they do it differently.
Okay. Because I'm like that gentleman. I have one that's got magnesium and like calcium supplement.
So about 400 milligrams is what you want to take.
Okay, great. Thank you.
Of course.
Oh, hello. I've been dealing with osteoarthritis in my hips for years, probably since the early 2000s, and it's getting worse and worse. And I take meloxicam almost every day, every other day. And I'm not sure if I should have a hip replacement. It's very painful and I struggle every day.
Are you Aetna by any chance?
Yes.
Okay, I'm looking at the chat to make sure I can answer everybody.
Okay.
Have you done injections into the hip yet?
No, actually I have an appointment today with a specialist. Good. I requested a specialist.
Good.
So I don't know if that's going to come up. I don't know if they're going to take x-rays or MRI or I don't know.
Can I ask you how old you are? If you don't have to give the exact age.
I'm 63.
Okay, and you've had it for how long?
I've been dealing with since the early 2000s. You know, first it's just like a little bit of pain and it's gotten worse and worse. And then
is it actually is it in the groin that bothers you or is it on the outside of the hip?
It's in the groin, so topical is not going to help and turmeric doesn't.
Very young. I would say definitely do in some sort of an imaging if you haven't yet. And then you're going to, the specialist should do all of that. So usually what we do is we do an x-ray. If it shows moderate or severe osteoarthritis.
It's moderate.
Okay, you already had it. So yeah, it's just really, you're really young. Were you like a runner or anything like that?
I think it kind of all started when I actually started taking yoga, thinking that it was going to help. And I think it just exacerbated the problem because I could barely walk every time I would go to a yoga class.
So I could tell you a lot of times groin pain doesn't always mean it's your hip arthritis. It could be that the muscles around the hip flexors are the ones that we unfortunately really don't take care of. So it's the muscles that go in front of the thigh. They're sort of going from your pelvis to the leg. Mm-hmm. Hip flexors can be very tight. So what they do is they push the groin into sort of where your hip feels like it's uncomfortable.
And that doesn't take much.
Yeah. Have you done physical therapy?
I've done like the exercises that they've given me. You know, I have like a list of exercises, and some of them I can't do because of my hips are so tight.
So when you say tight, I always wonder, is it the muscles that are really causing most of your discomfort? Now, the hip injection should help all of that because it's kind of it doesn't stay in the hip completely. It can kind of go around to the muscles too. But I would really encourage you to do a lot of hip flexor stretches because that's the biggest problem we all have. Do you have a sitting job a lot?
Yes, and I have I cannot sit more than 15 minutes. And I could barely walk. I'm like so stiff. My whole life is about being stiff and not being able to sit more than a half an hour when people get up from lunch and I have to kind of warm up. You know, I can't just get up. I have to bring a pillow with me wherever I go because if it's a hard seat, it's even worse.
So I would say you're the perfect candidate for swimming. If you don't do it, I would pick it up now. And then I would definitely follow up with a specialist and see, you know, the injection again should help you no matter what, even if it's minimal, like 20, 30%, but that doesn't mean you should just get the injection and then wait for the pain to come back. It means you have to work on your body. If you're that stiff that even getting up for lunch or you can't even sit for that longer than 15 minutes, you're really not taking care of your body right. You need to have mobility. So swimming is wonderful.
I can't do, I mean, that's kind of like, it's just very difficult to squeeze that in when you get off late from work. You know, it just can't be done. I mean, I did go swimming, do laps a long time ago, but it's just not practical the way that my life is set up at this time with this high volume sort of a job.
No.
It's
like, what about weekends? Do Saturday and Sunday, 1 hour. That's all your body needs. You're 60 something. That's really young. I mean, you know,
yes, I mean, the weekends you want to, you know, enjoy yourself. You don't want to be scheduled something else in your life that, you know.
I get it, but if you
swimming is in my hair. I have very kinky curly hair. So
swim
it's
cap,
like
girlfriend, swim cap.
Still gets in there. It's that bad. I mean, it still gets in there. I mean, it's vanity.
So this is what I always tell people. I mean, once you get it, you'll realize by spending that, let's say, because swimming does take a lot more time. So it takes about 2.5 hours of your day, even if you do 1 hour.
I mean,
but if you do the 2.5 hours, guess what? You're going to have the rest of the week much more enjoyable. You're going to have the rest of your weekend much more enjoyable. You're not.
You know, I was doing that maybe 5 years ago. I was going to the Venice pool and I barely know how to swim. I didn't learn how to swim till I was in my 40s or float. So I just really swim across the pool and I hold onto the side and I swim. I can't stop in the middle or I'll go down. I mean, I could do it.
Why don't you go in the short?
It didn't help me. It didn't do anything.
Go in the short section and I don't want you to swim. I want you to walk.
Okay. Oh, to walk, yeah, okay.
Because it's not about actually swimming, to be honest with you. I can't do it. And I would probably suffer if I have to swim. It's about mobility. And when you're in the water, your weight doesn't weigh down on your body.
It's not hard on the joints. Right.
And then do the injection and see if it's appropriate. And then I would definitely encourage you to do hip flexor stretches.
Okay, I'll bring that up to the doctor today.
Yeah.
So sorry to take all your time.
Okay.
Thank you.
You're welcome. I hope that helps. But take time for yourself. I promise you'll pay off. CBD. Interesting. So CBD is a little tricky. Somebody asked CBD/dosage. I actually don't really know if CBD by itself does anything. I think you do have to have some THC in it. I would say the ratio is 1 to 3. So 1 THC to 3 CBD. I do have some of my patients, to be honest with you, I don't know the dosage. Nowadays there's like malls with CBD and THC. They're nicer than any, I think, drugstore you can go to. I would just ask the expert there, but I do think that unless it has THC, it may not be very effective. Now there's like THC alpha, I believe, where they say it doesn't cause hallucinations, and there is enough data on that. So I'm not sure if that is appropriate enough to just have that in the CBD. I hope that answers your question, Carol. And then ice and heat, how long should it be in? Okay. You have to be careful about freeze burn. So I would say about 20 minutes is the maximum it should be on. I usually say 10 minutes because I think in 10 minutes you should get the effects and the improvement. My trick with heat is I heat it before I do stretches, because what that does is it opens up the muscle. It relaxes the muscle, so I can actually do the appropriate stretches and exercise without it being sort of tight. And I think I get the best benefits that way. And I think those are all the questions, right? I'm not missing any. Yeah, that's it.
No, it's not.
And what did you say? No, it's not what?
Oh, I'm sorry. Forgive me. I do have a question.
Yeah.
My question is, could you kindly address nerve pain in one's foot and sensation of pins and needles, neuralgia?
So it depends where it's coming from. So usually,
Yes.
if you have it at the bottom of the feet alone, like all throughout the bottom, that's peripheral neuropathy.
Mm-hmm.
And so usually with peripheral neuropathy, there's many reasons. And then there are some that we'll never know the reason. So some of it is diabetes, thyroid issues, chemotherapy, radiation. Some of it is genetic, but those are the ones that, and then some people, we don't even know the reason. And it's just, we just call it peripheral neuropathy. Now, if there's a distribution, so for example, the big toe, the bottom of the big toe and the top of the big toe, that can be coming from your back. So it all depends on where it is. Sometimes you have a pinched nerve around the ankle that's giving you a distribution of that nerve. But usually if it's an isolated bottom of the feet, it's peripheral neuropathy.
How about the side, the outer edge of one's foot and ankle pain?
Is it just the ankle and the outer edge of the foot? Is it top of the foot, bottom
Correct.
of the foot, or both?
Correct. Accompanied with neuralgia, pins and needles sensation. Yes.
Is it bottom and the top of the lateral side, or is it just the bottom of the back?
Just the outer edge of the side.
That could still be from your back. Or have you had any ankle surgery?
Oh, no. Mm-mm.
Yeah. So it could be many. I really wish. So if you look at it, there is a nerve that goes from, like, I would show you guys my feet, but nobody wants to see that. And the, you know where you have like the outside, like there's a little ball outside the ankle. There's a nerve that goes right behind it that distributes to exactly what you're describing. So if you ever had any injury or have a swelling there, it could be pinching on that nerve. But if you don't have any of those, it may be from your back, possibly.
Mm-hmm. What is the name of that nerve at the ankle, side of the ankle?
I believe it's the sural nerve. Let me make sure. I don't usually
it's the sural nerve.
I think so. Let me make sure though. I don't usually do feet, but there we go.
Just feet.
I can actually show it to you guys. So this is the nerve that, yeah, thank God for blurring. Let me undo blurring. No, let me do undo blurring. Trying to find you. Yeah, sural nerve. Mm-hmm. But let me undo the blurring so you could actually see it. It's pretty nice to see.
And the sural nerve runs then in the ankle and out on the outer edge.
The outer side.
Yes.
Yeah, exactly.
Mm-hmm.
Let's see if I can unblur my. Have you ever seen anybody for it?
Oh yeah, many.
Has anyone ever tried to inject into the sural nerve for you?
Yes.
Did it work?
No, no.
So this is the nerves, and then you could see the one that's on the side, right? That's the sural nerve. The other thing you could do is, have you ever tried topical ketamine for it?
I have not tried topicals because I'm allergic to most. My skin just reacts to everything. So
there's a compounding pharmacy that you can actually, if you know, most people don't know what it is because there's so many things in creams. You can actually specifically tell them what you're allergic to and they don't mix it with that component. But yeah, that's.
Thank you.
Of course. I had back fusion in February. Since then, my pain has increased in CT scan now shows problem at L2 with, more surgery. I'm doing PT twice a week. Is there more or is there different I should be doing? Susan, yeah, that's actually pretty typical, unfortunately. So they fix the part that you have an issue, and then the top of it gets kind of an issue because there's metals in there. You could try an epidural. Physical therapy is probably the best, but physical therapy for the low back and pinched nerve is a little tricky, especially when you actually have a pinched nerve with metal. I would say I would do physical therapy as you're doing, and then make sure the physical therapist is a good physical therapist, because that makes a huge difference. So there are good physical therapists and there are not so good physical therapists. I always tell people go to like a physical therapist that's gone, you guys did not hear this, USC training, because they're #1 physical therapy school actually in the United States. And they're all PhDs, which is really wonderful. But I would say try an epidural. You have to go to a pain specialist, or surgeons have PMNRs, like physical medicine, that they work with. So there's different routes to get to pain. There's physical medicine rehab, there is anesthesia, and then some psychiatrists are doing it too. But you may want to try an epidural before you think about the surgery. But that's unfortunate. I'm sorry. That doesn't sound fun. And then you could do the spinal cord stimulator before surgery. I would say do the epidural first, see how much relief you get. If it doesn't help, I would consider the spinal cord stimulator before you do another fusion, because then you're just going to go higher and higher, and then your mobility just gets a lot less. Hope that helped. Any other questions? Oh, here we go. I take no vitamins, hormones, or anything. I am sensitive and get woozy when taking them. Do you know of a multivitamin brand for sensitive people? The one that I really like that I use is called, oh my goodness, Vitamin Code. I don't know if it's for sensitive stomachs or not, but I just like Vitamin Code because it's, you know, I don't believe in one pill can supply all the nutrients and the vitamins you need. Vitamin Code actually need to take 6 of them a day. So I think it's a lot less in each setting, which I like. But to be honest with you, I'm not sure if you're eating well and you eat your vegetables and fruits, I'm not sure if you need supplemental vitamins. You know, I do believe in like our diet should give us everything. I did take vitamins for basically prenatal and then postnatal, and I don't usually I try not to take them because I do my vegetables, but I would try Vitamin Code possibly. Nowadays, there's a lot of different companies that are doing the more natural stuff, but those are the ones that like you have to do like a monthly subscription with them, and they basically make it fresh, so there's enough that much preservative in it. So you may want to look at those. So like to look up vitamin subscriptions or something like that and see what comes up. But yeah, I think we tend to do a lot of supplemental vitamins, which I think we should be getting from our foods, but that's good that you're not taking much. It seems like you're pretty healthy otherwise. Any other questions? Well, it was a pleasure. Thank you for all the questions. Makes me feel like I'm here for good reason. If there's any concerns or you guys have any questions, I'll have Maria send you guys my email. I'm good at emails, but not like so promptly. I've learned to just check my emails like every 2 days, just because otherwise I just go crazy with being on my phone all the time. And thank you. And yeah, that's it. Thanks so much. And I'll have my slides up. I just have to make one adjustment, and then we'll go from there. Thank you for the positive feedback, you guys. Oh, thank you.
Thank you.
All right. Pleasure. And Edna, I hope you get some relief with your hip. It sounds pretty uncomfortable and you use it all the time. So, but make time for yourself. Everybody. I mean, I should be saying that to myself, but I'm learning too, that I think the more we prolong our body, the more we'll pay for it later. And any patient of mine that comes to my office after age 85 and their first time in a pain physician's office, and they're very functional before that, is because they've taken care of their body. They've exercised, they've eaten well, they've done their stretches. They're very, very active people. So it sort of reminds me that I need to do the same for me to be there for my children and hopefully grandchildren. So take time for yourselves, guys. It pays off, and you're around for longer for your loved ones, which is nice, or functional longer. Okay, that's it. That's my 2 cents. Take care, everybody.
Thank you.
Bye.